Oh yeah.
Yeah. How are we doing? James, are we ready to kind of kick off?
Nearly. I'm going live on, as you saw, I was setting up.
James, are we ready to kind of kick off?
I mean, I think we should wait a minute past 7.
Okay.
Really?
Excellent. So yeah, whenever's good for you, James, we can take your lead on it.
That's fine. Yeah, I think we should go at like a minute past 7.
Yeah. So did you see patients today, or were you just working from home?
No, I'm on holiday this week.
Oh wow, okay.
Yeah,
Thank
I
you.
was on holiday last week and this week.
Okay.
So yeah.
Excellent. Did you get up to anything, or?
Well, I'm having my patio done. My dad and my nephew are doing my patio.
Oh, okay.
So yeah, so I've been entertaining them for last week and this week.
Excellent.
Yeah.
It's the right time of the year to get it done, I think.
It is. I think so, most definitely. I've been waiting about 10 years for this. I'm so excited.
Is it in the back or the front? The patio?
At the back.
At the back, yeah. Okay.
Yeah, it's quite a long garden.
Oh,
so
okay.
yeah, not particularly wide, but quite long. So yeah, but it was all old crazy paving before, with lots of weeds kept growing.
Yeah,
and I don't have the time to be bothered with it all.
Yeah.
And so I managed.
It's nice to get it done. Yeah.
So I managed to talk my dad into getting it done.
Growing up, we used to have a really long garden, and it ended up just being a football pitch. And then the minute that we were out to university and that kind of thing, my mum landscaped the whole thing. So it's broken into like 3 tiers, and very beautiful in her eyes, but totally useless for us in terms of football. We could play properly. Whereas now it's just something to look at.
Now it's just something to look at. Yeah.
Excellent. Dan, I'm not going to give you. You've got a few introduction slides as well, haven't you? On your.
I can do a little intro of me. Yeah, I generally, to be quite honest with you, I don't bother with. I just say it how I'll just tell them.
I'm going to give you a.
I think I get a bit sort of when people just when we have like 5 or 10 minutes of someone's life before they start, I'm like, okay,
Yeah. We're now being recorded. Excellent. So,
Diane, would you like to take over the sharing?
Yes.
Yeah.
You can share your screen.
No, I can't see.
It's right at the bottom next to the.
No, on mine it's up here at the top. There we go.
That's great.
Cool.
Excellent.
Can you see it now?
Yeah.
Great.
I'm going to give you a brief intro.
Okay.
From what I know, we're really honoured to have Diane here. She's hygienist and therapist to Linda Grenville, and she does a lot of whitening, and this is one of the kind of things that she's specially prepared for us, because she doesn't talk much about her actual subject area as much as I've come to understand. So it's an honor to have her here today, and she's the president now? Yeah, of the Hygiene Society as well. So it's a very busy role as well. So we're really glad to have her here, and she's going to take us through it not being just a clean. So Diane, without further ado, I'm going to hand over to you. Okay.
Brilliant. Thank you so much, Mish. Thank you, James, as well. So thank you, everyone. It's a pleasure to be here. And thank you for giving up your Wednesday evening to listen to this session. And so I hope you find some things of interest and useful in this. As Mish just said, this isn't really obvious, this isn't something obviously that I talk about a lot or speak about a lot, but obviously I have been, I've been a dental hygienist for 25 years. And next week it'll be 25 years since I first started working for Linda Greenwell in Hampstead. So I've been practicing all this quite a long time as well. So anyway, let's continue. So the aim of this evening is basically to inform those of you attending of the role of the dental hygienist and dental therapist using the S3 level stepwise approach for the treatment of periodontal disease in general dental practice. So the learning outcomes for this evening are to summarise the S3 level evidence-based approach to the treatment of periodontal disease, develop periodontal programs in a general dental practice using a stepwise approach and identify the appropriate time for referral, and identify the use of appropriate information, materials and technology to educate patients on disease progression. So we're going to go through, it's kind of in two halves this session. So the first part will be looking more at the guidance that's available to us and how all that links in together. And then we're going to look at then how we can put this all into practice. So when we have all this guidance and this information, how are we going to put this all into practice? So basically, so what I want to do just before I start is kind of define the role of the dental hygienist and dental therapist, because as the title kind of implies, it's not just about clean. And I think that a lot of generally what happens is, and I'm probably much more aware of it now in my current role for BSTHT, is that, you know, we're often like the hygienists used to be, not so much now, I don't think, thankfully, but but sometimes hygienists were very much under the stairs in a little room, and they would just scale and polish all day, see millions of patients, and that's how it would be. But I think we have developed on since that. And so there's much more to our roles and what we do. And I think it's important for everyone to kind of understand exactly what we do. So this is actually, I borrowed this slide from a different presentation that I did earlier this year. And this was kind of looking at how we present ourselves, how we're known, how we, you know, what it's described at. And these are some of the words that are terms that are used when a patient comes to see us for hygiene visits. So things like, I have one patient actually who loves how I dig, which I'm like, oh, every time she says, I love your digging, I kind of cringe. You know, ref hygiene, that used to be a referral from a dentist. When I was a dental nurse millions of years ago, H with a circle used to be the prescription for the hygienist. You could never get away with that now. You know, hygiene visits, scraping, scale and polish, things like that. So what we're going to look at is more about like the terminology that we're using now and how it's perceived now as well with the new guidance that we're following in practice. So to start with, the General Dental Council obviously has a scope of practice for all the DCP roles for the dental nurse, the hygienist, the therapists, dental technicians and orthodontic therapists. And the scope of practice was published in 2013. And I've just, this isn't, I'm a dental hygienist, that's what I did. I qualified in the time when it was dental hygiene. But obviously this is kind of a similar approach for therapists as well, for dental therapists as well. But dental hygienists this is how we're described as dental hygienists, are registered dental professionals, which is perfectly true, who help patients maintain their oral health by preventing and treating periodontal disease and promoting good oral health practice. They carry out treatments direct to patients or under prescription from a dentist. So a couple of months ago, I was on a focus group with the GDC on the scope of practice, and we're looking at the terminology because they are going to be reviewing the scope of practice, and it is going to be probably changed and added to and different things. Anyway, it's a huge project that they're doing, but they're working on it. So one of the things that we looked at, and one of the words that stood out to us was help. And we feel that we do probably a lot more than just help our patients to maintain their oral health, which we do obviously, but we felt that the group of us that run this focus group felt that we did much more than just help our patients. So that's one of the things. Now this is, so a few weeks ago, I provided some feedback on the notes that we'd made from our focus group meeting. And I was thinking, and what they're looking at is more of a statement about what we do. And this is something that I wrote, and I have to say that the original one that I sent to the GDC as part of my notes, I've actually changed it about 12 times since I put it on this presentation, because I thought it was quite useful. Like I wanted to sort of look where we were at now and where I feel we're at in 2021. So dental hygienists educate and support patients to attain and maintain optimal oral health throughout life, whilst promoting the links between oral and systemic disease, stroke health. They take a lead role in preventing periodontal disease, dental caries, tooth wear and oral cancer by providing appropriate education, treatment and interventions direct to patients or under prescription from a dentist. So basically, from this and looking at the research and what we're going to talk about tonight, there's much more of links between oral health, systemic health, which we all know about. You know, as a dental hygienist and dental therapist, we're more than just doing periodontal disease. We're looking at prevention of caries. We're also looking at tooth wear. I was fortunate enough to be on a working group with Professor David Bartlett from King's and Soha Datti from GSK. And they were looking, it was about BWE and tooth wear. And that was actually my first thing that I did as president-elect for BSDHT a couple of years ago. And I've been working on that for a couple of years with them. So I got involved in a bit and learned a lot more about the BWE and erosive tooth wear, which is just as significant as perio and caries. And obviously, you know, we all screen for oral cancer when we're seeing our patients. So I feel it's important that we kind of, you know, acknowledge that we have this holistic role within what we're doing as dental hygienists and also as dental therapists as well. I mostly commented on the hygienist, on dental hygiene scope as because I am a dental hygienist. So no one's approved this or looked at this or anything yet. I haven't had any feedback, but I just thought I would share that with you just to give some kind of idea of how I think that we have moved on since 2013. So the guidance. So there's lots of guidance out there, and periodontal disease seems to have an awful lot of guidance out there. There's lots of there's lots of help, there's lots of support. BSP have a fantastic website with loads of information on there as well. And you know, you can obtain lots of really good, useful information. Obviously we've got the BPE, we have there's Healthy Gums Do Matter, which is kind of more, it's a toolkit that looks, and it kind of runs parallel for NHS practice and UDAs, but you can use it in a private setting as well. It has the same kind of principles. Obviously the Good Practitioner's Guide to Periodontology as well, which is BSP's kind of Bible. So there's all this information out there that we can use, and we can use as resources. These are three kind of laminates that I have in my room in the practice where I work when I'm with Linda. And these are what I have all the time, and I have them out and I'm referring to them and looking at them and checking them the whole time. And when we get to how we can apply, you know, how we're going to put all this into practice, we'll look at these and how you can, you know, how you can utilize these little charts. They're really helpful. If you haven't, you should have them. Anybody who's members of various, if you're members of BSP, if you're members of BSDHT, of BADT, of probably the dental nurses had them. They you know, a lot of they were disseminated out across the profession as they've come out. So they're freely available for people to use, and you can download them as well from the BSP website as well. So these are really good flow charts, they're good references, and they're just those tools to help us to make sure that we're, you know, providing the right care for our patients, that we're diagnosing, and that we're, you know, we're doing what we should be doing in the best interest of our patients. So just a little bit on background on the perio before we start on perio disease. I'm not going to go too heavily into this because I'm sure a lot of you do already know this and understand this. So I don't want to bore everyone to death because we've got lots more exciting things to talk about in a little while. So obviously prevalence, periodontitis is the most common chronic inflammatory non-communicable, I can never say that, disease of humans. Global burden of disease in 2017 study, the prevalence of the severe periodontitis was estimated about 11%, which is about 743 million people. And then milder forms of periodontitis around about 50%. So that's quite high. That is quite high. So obviously the definition of periodontal disease is periodontitis is characterized by progressive destruction of the tooth supporting apparatus. So the loss of attachment, clinical attachment loss, the presence of periodontal pocketing, and obviously bleeding when we're probing, and that's obviously a major sign. Any bleeding when we're brushing and when we're probing is obviously an indication of active disease. And then radiographically, obviously, if we can see that there's been any bone loss, then we know, and if it's obviously vertical bone loss, then we know that we're looking at disease. So, so basically the BPE, this is your little flow chart for BPE. You can take I'll show you once in a second, this one, but you can take the scoring here. I have it as, you can have it as just take it out and make it bigger and, move it around. I did like a screenshot of it, and then I just put it on a big piece of paper so it's all there. And we have them in our rooms in the practice so that everybody, all the dentists and everyone has a copy of those. So obviously we know a little bit more about the BPE. This is obviously the basic. This is where we're starting from. So when we see that patient, this is where we're going to start from. We're going to do our BPE, and then that's going to determine the path of treatment that we're going to take with the patients and how we're going to work with those patients to make sure either that if they are healthy, that they stay healthy. If they're gingivitis, we get them back into health. And if it's perio, how we're going to deal with that. And that's what we're going to talk about this evening. So obviously you can see pretty straightforward BPE, two's lower anteriors and then one's maybe some bleeding. And so that's quite a, general kind of basic sort of BPE, very straightforward, nice, reasonably healthy patient. This one obviously a little bit more severe. Actually, I saw this patient a couple of weeks ago, and as soon as he opened his mouth and I saw her, I was like, can I take some photographs, please? So knowing that I was going to be doing this session. So anyway, so that was, there's more. We've got some code 3s, we've got some code 2s. Definitely, you can't see it too well on here. I seem to have picked up the wrong mirror for intraoral, but there's basically rings of subcalculus around pretty much most teeth, particularly on the lowers and on some of the upper molars as well. So I had a little go, and I will continue when I'm back at work next week. So the World classification, the World Workshop Classification 2017. So this is how we're basing now our diagnosis of periodontal disease and how we're structuring all this. And this is where we're going to talk about the S3 level evidence-based approach. So the World Workshop is it was a collaboration between the American Academy of Periodontology and the European Federation of Periodontology, and they met in Chicago in 2017. And they, as a workshop, and they put together the consensus that formed the new classifications that we are now using and have adopted in the UK. Their work was presented at Europerio. It was published in 2018 and presented at Europerio in Amsterdam in 2018 as well. So the differences between 1999 classification and the 2017 classification is basically now there is a definition for periodontal health, which is always good. They've replaced chronic and aggressive periodontitis to using models of staging and grading, which we've all been learning lots about how to stage and grade over the past couple of years. The support given to personalised medicine, so making sure that, once we've got that stage, we've identified we've got periodontal disease. Is it localized? Is it generalized? Do we have we've staged it, we've graded it, we've included risk factors, we've talked about the risk factors. Then that's when we start to then put our knowledge of how we're going to treat this into practice. But what we have to do is make sure that that's specific for that patient's individual therapeutic need. So that, and personalized medicine is very much how medicine's going, making sure things are very specific to that patient. And that's how it is for us as well in dentistry. And then they've also included peri-implant disease and conditions as well. So defining obviously periodontal health and gingivitis. So basically with health, we have no attachment loss. You've got pockets of less than 3 millimeters or less. Bleeding on probing is under 10%, is 10% or under, and there's no radiological bone loss, so you're not going to see any bone loss on any radiographs. Gingivitis, we still have, again, there's no probing attachment loss. Pockets, there's no pockets 3 millimeters or above. There's potentially over 10% bleeding with gingivitis, so we're going to have like 10% or over bleeding, and then obviously again no bone loss. So we know that we can reverse this. We know we can reverse the gingivitis. So making sure that we get a good periodontal examination is really important. And I talk about this when in my usual subject of tooth whitening. We talk about an examination for that. When we're going to do whitening, what it tells us, the guidance says we must have an examination. What's included in that examination, and it's the same for perio. So when I'm doing whitening, talk about perio, and when I'm talking about perio, talk about whitening. So basically we have so we've got a perio exam. So what do we need? We always need a detailed medical history and dental history as well. And I have put in brackets social history as well, because I do think that's pretty important as well. And we'll talk about that in just a short while as well. So making sure we have a good detailed medical and dental history, then we know what we're dealing with. We know medications, we know what the systemic issues are with that patient if they have any. Obviously, we're going to do full extraoral and intraoral examination. And then we were going to do our probing, pocket probing depths as well. So 6-point pocket chart or some kind of probing as well. You'll notice on here, I've put this, this is a probe, this is a UNC 15 probe, which is kind of the probe of choice generally for most clinicians when they're doing pocket probing depths. So that one, it's nice because it's at 3 and then 5 and then 8, 3, 5, 6, 7, 8, and then 9. So, and it goes up to 15, but that's usually quite a nice probe. I have one of those on all my trays. Really like it, and I use that an awful lot. Very handy for fissure seals as well, running fissure seal into fissures, I find. We're going to do our record our, sorry, went back. So we're going to record our pocket probing depths, and then obviously we're going to record the bleeding as well. And then when it's appropriate, we will do any special tests and any radiographs and make sure that we get a full radiological support report. So radiographs can be, depending on the severity, could be bite wings, it could be PAs, full mouth PAs, it could be OPG, whatever is most appropriate for that patient. Or it could be a combination. Classification of disease. So this is a fantastic chart, and as I said, I have a copy of this in my room at the practice, and I think there should be ones in the other rooms as well, but I know I definitely have mine there to refer to when I need to. So, but a really fabulous chart, really breaks it down for us, makes it really easy to understand, and it's just basically just filling in the blanks really as we're going along. So, so you can see how we've got it refers back to BPE to start with. So how we're going to have our code 0, 1, and 2s, and then we've got code 3s and then code 4s, and then how we're going to approach that. And then the flip side of it is then the staging and grading of the disease, and then obviously we have and then how we're going to do the assessment. Is it stable? Is it unstable? And then it has a really nice at the bottom, there's this really nice just little statement on how to write your diagnosis basically. So it gives you that really nice overall thing. So it's a really, really handy like flow chart to have in practice. And I would recommend that if you haven't got one, make sure you download one. You can download it from BSP website. So make sure that you do that because it's worth having. So staging and grading. So basically this is based on upon attachment loss and like attachment and bone loss. And it classifies the disease in 4 stages of severity. So we have mild, early, and mild, moderate, severe, and very severe. And you'll notice that when we're talking about the S3 guidance, It only has stages at staging 1 to 3 at the moment, and 4 is going to be available next year. The evidence on that will be available next year. Grading is basically the rate of progression. So how fast that is going. So how fast the patient's losing bone loss, how fast the disease is progressing as we move along. So is it a grade A? Is it quite a slow progression? Is it a moderate progression, which is B, and grade C is more rapid. So you might see quite a lot. Our colleague Ian Dunn talks a lot about, he does to be or not to be. Is it to be or not to be? So that's he talks about that quite a lot when he does his courses. So so diagnosis. So basically the classification is we're going to have that. The classification is basically the stage and the grading of the disease, and then we're going to look at the status. Is it more generalized? Is it more localized? And then we obviously look at patient's risk factors as well. Now, this one I found, this is really interesting. This is from it's quite a new report that's it's The Economist, and it's quite a nice booklet. I've put a photograph of it towards the end for further reading. I think I have, or it appears somewhere. I'll find it if not. But I got hold of this a few weeks ago actually, and I was looking through it the other day, and I'm actually going to put it on my iPad and read it more when I'm on the train going to work next week, because I found it just really interesting. So so risk factors. So obviously, you know, we're very much aware of the the risk factors of periodontal disease that are, you know, well publicized and we've been working with for a long time. And obviously, you know, smoking being the main one, alcohol, poor diet, and then patients with cardiovascular disease, diabetes, type 1 and type 2. And then we all know about, obviously, pregnancy as well, and adverse outcomes with pregnancy. So those kind of ones that are the major ones, obviously the stress as well. But what I found quite interesting is that they're first in The Economist, and this is looking at the economic impact of periodontal disease. This whole piece of work is looking at basically the economic impact of periodontal disease in and around Europe, basically. And interestingly, the first risk factor they start with is age, and 30 to 40-year-olds is quite high prevalence, and then but higher prevalence is in between the 65 and 74-year-old patients. So these are the ones that we probably need to keep our eye on a little bit more. Obviously, and also this week, in the past couple of weeks, there's been quite a focus as well on menopause. So ladies, when they're going through menopause, that can obviously has an impact as well on periodontal disease. And so around that kind of time as well is quite an important time to look at the patients and consider those patients as well, you know, sort of late 40s, early 50s, menopausal patients. So around the 30 to 40, so basically from about 30 to about 75, you need to be really careful with those patients and keep monitoring them really, really well. Younger populations, not such a problem. So like the younger age groups, perio is not really a major factor at all, really. So it was something like 1.7% of the population in younger. It just said younger adults. It didn't give an age range on that. But 30 to 40-year-olds and 65 to 74, which I thought was quite interesting because that was actually the first risk factor. Just said risk factor, age is going to be a major issue. Then it also talked about, before it got onto lifestyle, and then it talked about periodontitis being a social disease. So it's relating to, you know, poor oral dental care routines. So patients that are just not brushing, they're not engaging, they may not even go to the dentist, you know, for whatever reasons, they may not go to the dentist, poor access to dental care, and then obviously less frequent visits. So, you know, we may have seen an increase this year, in this past year because of the pandemic and people not going to the practices quite as much. And then areas of social deprivation, you find periodontal clusters in those areas well. Now, obviously, looking at particularly the social disease and the lifestyle, these two are very, very interlinked. So what you'll find is so often what you do find, not always, but often what you do find is that these kind of areas of society that maybe have, have less access to care, less frequent visits, more those areas of deprivation, they're more likely to have more incidence of cardiovascular disease, diabetes. Now they're looking at links between chronic inflammation and particularly perio with regards to dementia. And they're also looking at tentative links with cancers, rheumatoid arthritis and respiratory diseases, mainly because of those links with those inflammatory proteins. So, having that inflammatory response consistently is causing that kind of, those links with these other conditions as well. So this is really, really important. And this is something that we really need to address with patients and look at patients as well. And also, reflecting back on the social aspects of it as well, and those communities. Many years ago when I first qualified, I worked in Camden in Northwest London. It was NHS practice. It was a learning curve. It was definitely, for me, it was definitely a learning curve. I grew up in the north of England. I brushed my teeth twice a day, was told to brush my teeth twice a day, went to the dentist every 6 months, did everything I was told. I eventually decided I wanted to go into dental hygiene, and went off to Guy's, trained as a hygienist, qualified, landed in this practice for 2 or 3 days a week in Camden. And one of the first patients I said to the patient, how many times a day do you brush your teeth? And he looked at me and said, I don't. And that was quite an awakening for me as well. So, we have to look at that wider thing with these patients as well. I think that was really interesting. So definitely risk factors, very, very important to be considering. So here is a good example of a diagnosis for patients. So when we're doing we're going to do our BPEs, we're going to do our periodontal examinations, and then we're going to stage and grade, check obviously risk factors, those kind of things. We're going to check all that, and then this is how we would write it. So our general statement would be somewhere around generalized or localized periodontitis. The stage, so is it stage 2? Is it this one? In this case, it's stage 4. It's grade B. And it's currently unstable. So there's obviously bleeding, there's pocketing, and it's kind of it's progressing with probably the patient's in line with the patient's age, but it's kind of quite a severe case of periodontal disease. Major risk factor is that the patient smokes more than 10 cigarettes a day, and they don't have very well controlled diabetes, which obviously, as we know, diabetes is a contributing factor as well. Obviously, is a major risk factor, and obviously that's bidirectional. So that patients, obviously, if they have diabetes, they're more inclined to have periodontal disease, and if you have periodontal disease, you could be swayed more towards diabetes as well. So, and there are some studies that showing that if we are reducing the inflammation in our diabetic patients, if we're reducing inflammation there, then that can lower their incidence lower with the diabetes as well, and improve their markers with their inflammatory markers with diabetes. So that's really important to know as well. So as I showed you this photograph before, this is the patient that I just saw a few weeks ago. And you can see, obviously, there's lots of subcalculus that's quite visible on those lower anteriors. There was, as you went around probing, there was lots more lingually, palatally, incidentally, and you can see on these radiographs as well. You can actually see on the bite wings. The bite wings were taken before I saw the patient. So he'd seen the dentist, and then he was seeing me for hygiene. So I had the bite wings. There was the pocket charting. I'll show you the pocket chart in a second, but you can see there has been some bone loss. This patient's around about 35. So there has been some bone loss. There's a little bit of vertical bone loss here on this upper right, and there's some bone loss on these lowers as well. So these are all areas that we're going to show the patient, and we're going to work with the patient to make sure they're cleaning incidentally, but also that we can show them where the bone loss is. And from our point of view, from the diagnosis point of view, we want to be looking at the bone loss there. I did like this might be quite nice as well if we did have some PAs for this patient or an OPG. as well would be quite good as well to look at. This was the pocket chart. So it's pretty much 100% plaque. Bleeding score was 37.1%. So that's very much generalized bleeding. So we know that there's more of a generalized inflammation. And then you'll see the pockets around the molars. There's some 4s and 5s on the upper right, and a couple of 4s upper left palatally as on the buccals as well. And then lowers around about a 3s. There was just the odd 4 and 5. There's a couple of 5s around the 8s as well. So if we look at that patient, then that patient's probably somewhere like sort of probably around about stage B, maybe B. I think it's around about B. 1 second, let me just go back. I'm going to just check. Yeah, so it'll be like probably grade B. So probably 2, stage 2, grade B, that patient. And risk factors, he did used to smoke, he doesn't anymore. So he is a non-smoker. So I'd probably say around about, it's probably like a 2B on that one for that patient. A good one thing that I learned when I went and I did my my perio courses in 2018. So I went off and I did the course with Phil Hour and Ian Dunn. And one of the things that was really good, we did, they showed some OPGs, and there was one OPG that Ian showed, and it was basically rapidly progressive on quite a young patient, and everybody in the audience just went, oh! and he said, just hold that thought for 1 second. And actually, one of the things that a good way he said that to work it out and to look at when you're looking at a patient's radiographs, when you're trying to make the diagnosis, if you had like an OPG or some full mouth PAs, or even, if you've got some pretty decent bite wings, if you look and it's kind of what you expect for that patient's age and the situation, then it's kind of somewhere around a grade 2. If it's much more than you think that it should be, if it's worse than you think it should be, then you're looking more at 3. And if it's not as bad as you think it should be, then it's a 1. So that's kind of a good way and really easy way to understand the progression of the disease. So I thought so I kind of try to keep that in my mind the whole time whenever I'm trying to work all this out when we're doing this. So, okay, so the S3 level clinical practice. So this is what we were going to talk about a little bit tonight. That was just the kind of build up to this. So you can see that basically all these things fit in. So the BP leads to the classification, and then the classification then leads on to this. And the idea of this, the whole aim of this piece of guidance is to combine the evaluation of a formal evidence and basically a formal evidence grading and the synthesis with clinical expertise. So basically what they're doing is they're putting this whole workshop, this whole working group that went through all that. They looked at the evidence and then they basically fitted it into how this all fits in with the classification. So basically, once you have that classification, how are you going to treat that patient? And what they were looking at is that how are you going to do it and with an evidence base behind it. So everything that we're doing has to have the evidence base. And this whole guidance is aimed at providing the evidence base for the treatment that we're going to do in line with that classification. And that's what it was all about. Now, this was originally done by the European Federation of Periodontology. And then as they did with the classification, BSP then got hold of it and made it workable for the UK health care environment. And so BSP put together a whole big workshop, and they had lots of different stakeholders, which is the organisation, so all the different professional organisations. BDA, there was representation. BSDHT, we had Leon Bassey, who represented us on the working group. Debbie Hennington represented BADT. They had, obviously many people from BSP in all their different areas as well. So there was lots and lots of input from not just BSP, but from the wider profession within the UK. And if you look at the paper, which is the one that I've referenced here, it has a whole list of everybody who was involved. And they had different workshops. They looked at different parts of the evidence that and the guidance that the European Federation had put together. And then they kind of went through it and looked at it, and how does that fit in with the UK? Is that in line with us? So when you go through it, it basically has that if they've adopted the European Federation's recommendations, or are they still looking for more evidence, that kind of thing. So it's a nice piece to look at, and there's lots of little charts and things to look at so that you can kind of follow it quite nicely. So and look at what they're suggesting and then the evidence behind it. And then BSP and their working groups have then decided, yes, we're going to follow this. There's enough evidence. The evidence is good, or no, the evidence isn't as good, or and they're either adopting or they haven't. Most things they have adopted. Most things they have. So before we start with any treatment with our patients, we need to make sure that we inform the patient. We must always inform the patient of what the current situation is before we start the treatment. If we don't inform them, they won't know. They won't know what's going on, and they don't know why the treatment's being carried out. And that's what we're going to talk about in just a short while when we get on to how to apply it to practice. So basically making sure we have the diagnosis and including the causes of that condition. So what is the cause? So we've got this diagnosis. What potentially is the cause? Is it plaque induced? Is it trauma? Is it something that's more systemic related? So something systemic health, that kind of thing, risk factors. And then what are the treatment alternatives? What can we do for that patient? What can we arrange for that patient? How can we treat these patients successfully? And then also, what are the expected risks and benefits of the treatment options? So like everything, when we're doing a treatment plan, we have to prepare them for what's the best, the gold standard, and then what the alternatives are, depending on that patient's situation. And obviously the risk and benefits that go with those as well. And then it's really important that we make sure that the patient is in agreement with what we've discussed, what we've talked about. They fully understand what is happening, what the treatment involves, what their responsibilities are going to be. Because as we all know, with perio, it's very much a two-way thing. I always say to the patients, it's teamwork. We have to work together. And actually what you do at home is much more important than what I do for you when you're here with me, apart from the obviously the educating side of stuff. But the actual physical treatment is probably, what they're doing at home consistently is much better, is what's important. So they have to be engaged, they have to be on board, and they have to understand what's happening. So step one is behaviour change. I'm going to just go over these relatively quickly because we're going to go back over this again in a bit more of a context of how we're going to fit it into practice. So this just gives you that kind of build up to it and that sort of prelude to it. So basically step one of the guidance is about behaviour change. So how we're going to motivate our patients, undertake successful removal of supragingival biofilm or disturbing the biofilm, any risk factor control. And then the interventions that we're going to do is obviously we need to improve the oral hygiene and make sure that's effective, any adjunctive therapies that we might need, and then any PMPR, professional mechanical plaque removal, and then risk factors, obviously. So the first stage of therapy is really is basically we should be implementing this with all our patients. So in all patients with periodontitis, we need to make sure that we're doing this as well. And we also just need to make sure we would do stage one with a healthy patient to maintain health, and we would also do it with gingivitis patients as well. So we're going to motivate, ensure that they adhere to all this. This is for the perio patients. We need to develop skills in biofilm removal and make sure we do that with the patients. That's what they need to be doing at home. We need to allow appropriate response to ensure the therapy as well. So basically we have step one, and then we're going to evaluate. So after we've done step one, which I'll show you the chart in just a short while. So after step one, we're going to evaluate, we'll reevaluate the situation. If we have a non-engaged patient, so the patient hasn't really responded to step one, they haven't really taken on board for whatever reasons, who knows what the reasons are. It may be that, COVID hit and we've lost that motivation. It could be that they've been sick, they could have had illnesses, there's all sorts of different reasons why people might not engage. So if they haven't, then we're going to give them another opportunity. So we'll put them back on step 1 again, and they'll continue, they will repeat step 1 again. It may be if you've got an engaged patient and we see some improvement, and there's criteria for that improvement as well, which we'll talk about a little bit later. Then we can move them to step 2, and they can also be considered for referrals to the periodontist if they need to be. Step 2 is about cause-related therapy. So making sure, finding out what that cause is, reducing or eliminated any subgingival, biofilm and calculus through instrumentation. And so again, we're going to make sure we check their home care, any risk factor control and behaviour change. So we have to work on the behaviour change. Subgingival instrumentation, and that can be powered or by hand. And the evidence is saying it's the outcome is the same for both. There was a lot of worry last year going back into practice after the first lockdown, because particularly from a perio point of view, there was, we were advised not to use AGPs, which obviously, as we all know, ultrasonics is a major AGP. And so it was much more hand instrumentation. So my colleague Claire McCarthy spent a lot of hours on Zoom teaching lots of people how to do good hand instrumentation on the webinar, via webinars. So it kept her very, very busy. But so hand instrumentation, the evidence does show that it can achieve the same level of response and you can get the same results. It does just take longer than using ultrasonics. Obviously, as we know, powered instruments, that they have their benefits as well. And it can be a combination of both, very much a combination of both. So one or the other, or a combination of both, is absolutely fine. And then the use of any adjunctive systemic antimicrobials, and that's determined by a level 2 or level 3 practitioner. So step 2, we go from then step 2. So then it's after step 2, we're going to reevaluate 3 months after we finish step 2. If that patient is stable, then we'll move them on to step 4. If they're unstable, then they go into step 3. And step 3 is basically treating that non-responsive sites. So it could be that, the patient has had some responses in some areas, but in other areas not. And so that's what we need to work on. So basically the interventions for this are home care, risk factor control and behaviour change. You can see there's a pattern here. Repeated subgingival instrumentation, and that can be with or without adjunctive therapies. And we'll talk about that in a little while as well. And then consider referral for pocket management. So any like regenerative surgery and that kind of stuff. So any bone regeneration, flap, pocket reduction, those kind of things. So we can look at those as well at that point. If they're stable and they go to step 4, or if they have a successful outcome from step 3 and they then have a successful outcome, then they can go to step 4, which is described as maintenance or supportive periodontal care. I like supportive periodontal care because I think that's what we do. We're supporting that patient. So we maintain periodontal stability in all treated periodontitis patients, combining preventative and therapeutic interventions defined in the first and second steps of the therapy. So again, the interventions for this are, as we said before, home care, risk factor control and behaviour change. And then we're going to make sure that we do regular, so any RSD or PMPR, and we make sure that we do check and we really target those sites. So I often with patients, if they've seen Richard, who's our periodontist, he might refer them back to me and say, Diane, can you just make sure that you see this patient every 3 months? And I want you to always make sure you focus on those areas, on those specific areas that may be 4, 5, 6 millimeters that we still, that, they're just there. We just need to make sure that we maintain them. So, and maintain them in a healthy and stable state. So, so that's what we would do. So we just make sure we target those particular areas, obviously not neglecting anything else, but focus on those areas, particularly with the patient. And then again, individual tailored intervals. So depending on the severity, we'll look at the intervals for recalls as well. So around, a lot of perio patients are around about 3 months. And then obviously, if we've got healthy patients, we might extend it out to 6 and 9 or 12 months. So we have, so just to define what we would say as an engaged patient or a non-engaged patient. So engaged patients are basically that they have, they've improved their plaque score and their marginal gingival bleeding scores, they've reduced by at least 50%. Their plaque scores are below 20%, and their bleeding levels are down less than 30% as well. And they've met the targets that we've outlined in their plan. So in their goal setting, they've met those targets. So if we give them targets of 25% bleeding, they've met that target. Okay, so that would be engaged patient. So it's basically a patient who is, you can see that there's been an improvement. They've made those improvements and they're working hard to keep up the improvement, and they're making good progress all the time. Those non-engaged patients are those that we just know we're not getting anywhere. They are, they've had a less than 50% improvement in their plaque and bleeding scores. Their plaque levels are more than 20%, and their bleeding scores are more than 30% as well. And then obviously that patient, we just need to make sure that we work with those patients and find out, first of all, before we go into this kind of more palliative approach, why is that patient not engaged? Is there a particular reason? And it may be just some talking to that patient and investigating a little bit further as to why they haven't been able to engage in this particular course of treatment. And so we need to look at that and see if we can help them in any way. And if we find that we're not in a situation we can do, then for a time, or it may be that for the time being, they're not in a situation to focus on this. So we put them into that palliative approach, and then maybe in a year's time or 6 months' time or something, they're in a better position that they can then work to become more engaged and really help to improve. Everyone goes in ups and downs and phases. I've had patients that come into me and say, it's just not worked this time. I just haven't been as good. I haven't been as diligent as I usually am, and then they tell you all the reasons why. And we all go through phases like that. We all go through phases. So this is, basically this is just like a really nice, simple chart. Again, that has been put together, and this is just showing, it's basically just showing, how we're doing this, how we're going to approach this, the different steps. So it's that nice flow chart again that we can refer to in our practices, and we've got to hand. So always make sure that you have this, and then your classification. And if you have both of those, you can't really go too far wrong at all. Do we have any questions or anything, Mish? Don't know if he's there.
I am still very much with you. So
I thought that was a good time to pause.
And it was also a good time to come in. So yeah, that's what I'm going to do is I'll ask the question. I've answered it, but just kind of your
okay.
on it as well. The question was, in terms of if you've got a 30-year-old patient that has 8 millimeters of recession labially, but no interdental bone loss on the radiographs, how does that affect the staging and grading of that patient?
Did you answer that?
Did you get the question though?
No, I couldn't see it. Oh, so it was basically they've got 8 millimeters of recession.
Yes. So like labial recession, and there's no radiographic bone loss.
Okay, so that could have been by like ortho or something.
Yeah,
like
exactly.
That,
yeah, ortho,
yeah.
Buccal kind of bone loss, leading to soft tissue.
So
loss.
the guidance was that you don't, if there's no evidence of bone loss through periodontal disease, then we wouldn't. It was more of this. Is that right?
Yeah. So it's
You're
more
better at this.
It helps to have.
I feel like I'm being tested now as well.
No. I don't want to answer the questions.
Yeah. So I would have said it would probably not be because because the staging and grading is only if there's bone loss, isn't it? An interdental bone loss. So
radiographic bone loss.
Radiographic bone loss. So that's part of the key thing for that staging and grading. So I would probably say not in that case.
Yeah.
Because it could have been.
The difficulty is that, and that's, one of the problems with the classification to a certain extent, in the sense that it doesn't look at, it looks at only interdental bone loss and not lingual or buccal bone loss. And, without CBCTs, you can't reliably check that. And that's not the point of a classification, but, you can say that isn't an issue with the classification per se. But
yeah.
And in terms of, are there any other questions here?
I can't see anything.
No,
there's one
coming up. Okay, so Rogan.
How do the structure of these appointments for NHS perio patients when working with you. Now I've got that towards the end.
Okay, so you've got like,
Logan,
like a kind
I
of
have
work
that
example.
towards the end.
Okay, so
Because there's a really good, there's a nice piece that BSP have put together on that one. And I was lucky enough to be on the webinar it was a Chief Dental Officer meeting workshop, and Ian Chappell was presenting on that as well, and it was fabulous. So I will, but there's a piece at the end on that one, because they've worked it out how you can do it, and I've got the document so we can sort that out.
Great.
Yeah, but I will talk about that towards the end.
I've got kind of questions around, so I think some of it is related to where we are in terms of the NHS as well, but I think some of the issues are related to the actual new systems and backlog and so on as well.
Oh, okay. Brilliant.
You just
My daughter telling me that I'm not supposed to be here.
Oh, okay.
Excellent. So should we continue on?
Can we just carry on? Don't we carry on?
Good idea.
I'm doing good time. Okay. Oh, we're doing all right. Okay, lovely. Right, let's carry on. Okay. So oh, I can't get rid of this. 1 second. Sorry, it's just doing something and I can't get the questions to go. 1 second, sorry. Oh, there we go. Right, done. Okay, right, I'm good now. Right, so putting all this into practice. So this is what I kind of do on a sort of nearly a daily basis, pretty much. So we'll talk about this. Got lots to tell you about this. Okay, so basically we've got a few things we're going to just talk about in this like kind of second half or so, maybe just a bit less. Okay, so basically whatever practice needs, team meetings, protocols in place with following the guidance, procedure analysis and structure, and then appropriate fees and banding as well, and teamwork. So we all need a team. First of all, we all need a team. And my last little bit is about teamwork. And I always kind of finish with that because I think it's a really good positive way to sort of finish a presentation such as something like this as well. I also feel I am probably a huge advocate of teamwork and delegation, and partly because I've been very fortunate in my career as a dental hygienist, primarily with Linda, that I have been able pretty much since the 1st of September of 96, been able to work to my full scope of practice. So I'm always very grateful for that, and I will always push for that and advocate that at any given opportunity. So I do. So making sure you have a good team around you, making sure there's a team and there's a team approach to what we're doing, because it is all about that team. And actually, the most important person, whenever we do any team training in our practice, I always ask, who is the most important person in the practice? And you'll get someone who'll say the dental nurse, the dentist, rarely do they say the hygienist or the therapist, but anyway, but actually the most important person in the practice is actually the patient. Because if we didn't have the patient, we wouldn't have the practice and we wouldn't have our jobs. So it's important that we all work together as a team to make sure we keep those patients with us all the time. So as I mentioned a few times before, these are 3 key documents or 3 key laminates, I would say, that should be in every surgery in your practice all the time for referring to as well. There are a few other ones that I have that are very useful as well. So there's BWE ones, and there's a Chalicum scale for saliva. And so actually, I don't know where there's any caries ones, but anyway, we'll find something. But there's lots of them out there, and it's always worth having. But from a perio point of view, definitely these ones. There should be always some kind of learning materials, things we can educate our patients with, and we'll just talk about that in just a short while, in a little while as well. So different things that we can do to help to educate our patients as well, which is hugely important. And then we need to make sure that we've got all the right equipment that we need. We've got our oral hygiene products that we're going to show and teach our patients how to use. and what to do with. We need the right equipment, things like cameras, intraoral cameras, and we'll talk a little bit about that as well. So we'll definitely do that. And then making sure that you have all the right instruments. You know, I'm fortunate, and I've predominantly for most of my career worked with Linda, which I pretty much, you know, I've always had good instruments there. I've had materials, I've had, you know, instruments that I need and everything that we need. And then you go into, I've been into many other practices where I literally went and bought my own stuff and took it all in because there was nothing, even down to Profi paste and Profi cups in one practice. So, and I won't say why, but anyway, so, you know, that's what, so making sure that you have the right stuff. If there's hygienists and therapists on tonight, you know, who are self-employed, you know, anything that you buy, if you buy it for yourself to use, it's all tax deductible. And actually it's a really good way to prove that you are a self-employed person as well. So I would always advocate that as well, where possible to do. If you can do it, you know, because it can be well within your best interest to do so. Okay, but making sure you have all the right equipment and the right materials as well. So team meetings as part of a team, this is, I talk about this quite a bit with regards to making sure that we're working as a team and building that team as well. And there's various team meetings that we do. I'm not going to go into all of them because they're not all specific for tonight. That could be for another time. But I will go into, but I just will briefly mention. So we have daily huddles, which are like daily meetings, very short, very sweet meetings that just deal with what's going to happen, not just that day, but the next day and the next week. And that just keeps the whole team together. We can have weekly departmental meetings. So it could be that the hygienists all get together, well, the hygiene and therapists get together. It could be that the dental nurses all meet to talk, the dentists meet, the specialists, whatever, you know. And then you can have interdepartmental meetings as well, where you may have the dentists, the hygienists and meeting. And then you can have full monthly team meetings as well. And we would generally try and advocate always to have good monthly team meetings where you have as many team members, depending on the size of your practice, as many team members as you can in one place. And also there's team training, and that can be done in a variety of different ways. I'm just going to just talk a little bit about monthly team meetings and training, because this fits in with what we're talking about tonight. So on a monthly team meeting, it's really good to make sure you reserve some time for all the team. If you're going to do it at lunchtime, then maybe the practice owner or whoever or someone can make lunch, bring lunch, buy lunch, whatever, so that people don't have to start going off and getting their lunch and then coming back and all that kind of stuff. And it just makes things easier. And sometimes, you know, some of the team are giving up their lunch times to do this. So, you know, it's a nice thing to do. It's a nice thing to do. So make sure you reserve some special time for that and try and do that every month as well. This is a really good opportunity to focus on a particular topic. And obviously tonight we're going to talk about perio, okay? So you might need more than one. You might need a couple of different team meetings, but to focus on this, you could get a copy of BSP's Good Practitioner Guide, or you could get Healthy Gums Do Matter, and you could start working through them, maybe give them to the team as a little bit of pre-reading, just to, you know, go through, make sure that they're familiar with it, understand it, and then start to go through it as a team so that everybody knows. And this isn't just clinicians, this is front desk team as well. So the front desk team need to know, the clinicians, the dental nurses, the hygienists, the therapists, the dentists, the specialists, everybody needs to know, everyone should know. And basically start going through these, looking at them, looking at, you know, and how you can start to implement these things into your practice. What you can do is just get those flow charts as well. You could use these as some backup, but you could just get the flow charts and start looking at those as well. Review the current guidance and make sure that everyone is familiar. Make sure that everyone's familiar with all the guidance. And as I said, it's the whole team, not just the clinicians, And then what you would do is then identify, if you want to have that more team approach to it, have everybody involved, identify what the roles and responsibilities of each of the team members are and how this can fit in with the current guidance, and how you can start to implement that using all your team members. So on the kind of the step approach, that one, there is actually a little bit at the bottom of step 1, the last line actually states which members of the team can do which parts of step 1. So the dental nurses, the oral health educators can be involved, the hygienists and therapists, and then what the dentist would do. So it tells you what they can do. And then plan how that team can work towards implementing this guidance and recommendations. So how are you going to put all these things in place, and how we're going to make sure that everyone can be working to make sure that we get these. And then obviously every good team meeting always has, you have to establish some action points and set some SMART goals to work towards, that everyone can be accountable for, so the whole team can be much more accountable for. And then make sure that you always set a date for the next team meeting as well. And that's really important that you do that, because otherwise we want to make sure that we keep on this path. And as I said, it may take something like the Perio one may take 2 or 3 even team meetings, and then it may be that you move to something else and then come back to that later. So these things do take time. They're not going to happen just like that. And it's also good, and it's, you know, by having the whole team involved, you get different perspectives as well. So, you know, rather than just maybe the hygienist and the therapist working on this, I mean, they could lead on it, but you would get different perspectives from the dental nurses, from the dentist, maybe from the periodontist. They would look at different things as well. And then team training is basically, the team training side is identifying those skills for each of the team members. So identifying what skills those team members have, and then what they can do, or what they might need to learn. Do they need to learn? Do they need to have any additional skills? How can we go about this? So what skills do they already have? And then what we're going to do. And this can be done, obviously you can find out these things in an appraisal situation, something like that. But to implement these, if we're going to start implementing, you know, the stepwise approach to treatment, how are we going to utilize all our team members? Do they need to, is there anything else that they need to do? Is one of our dental nurses going to take on that oral health education lead? May need to go and do the course. You know, is the hygienist, do they need to make sure they brush up on their classifications? You know, that kind of thing. So making sure everyone's aware. And then, can we use these additional skills and knowledge? Can these be taught in-house, or do they need to seek sort of external guidance as well? What I would always recommend, and I get this probably a little bit more with whitening, is that I often get hygienists and therapists, because we teach those courses as well. But when they come in, like I get some emails saying, can my dentist teach me about tooth whitening? And I say, well, possibly, yes, they can, but you need to know what training they've done. So, you know, before you start, because obviously they may not have done training, or they may have done, you know, an online course for 2 hours or something like that, which may not be enough. So make sure that you know, if you're going to do in-house training, make sure that you know where that training is coming from, and what levels, you know. So if we were doing some perio stuff and it was Richard, our periodontist, I would be quite happy to learn from him, because he's the periodontist in our practice, and we expect that he's on his game with the perio. You know, we wouldn't necessarily go to Jude, who's the endodontist. But if we want to know a bit more about endo, we go to Jude, because he's the guy who does that. So, you know, utilize a specialist, that kind of thing. So have a look at that and just consider that as well. Do we need to have any additional skills and knowledge that we need to learn externally? Do we need to go on other courses? Do we need to learn from other people as well? And sometimes by doing that, you get different perspectives, and we learn in a different way and in a different context as well. So there's nothing wrong in it at all. There's nothing wrong in doing in-house either. And then, do we need any other skills or formal qualifications? So do we need to go and get any formal qualifications to be able to do anything that we're doing? So as a dental nurse, if they want to do oral health education, they would be expected, and they should go and get their official qualification in oral health education. You know, so things like that, those are the kind of things I'm looking at. So that would, one of the other things I was going to say with this as well, with team training, didn't really put this in here, but quite a few years ago now, I was doing some practice management work for a company called Jameson Management, and I was working with a practice and we were doing some training with them on practice management stuff. And we did, and they were a pretty clued up team. And one of the things that I did with them, instead of standing there, because one of the sessions is about perio and teaching perio. And as I said, they were quite clued up. They sort of knew what was going on. And I felt it would have been a bit insulting to them and a bit condescending for me to stand there and teach them about perio. So instead what we did, and they really, really enjoyed it. And I actually really enjoyed doing it. And I'd love to do it again sometime with another team. But we split them into 2 teams, and each team had a dentist. I don't think there was a specialist in each team, but there was a dentist in each team. And then there was a hygienist in each team, a dental nurse, a front desk person. So there was kind of each of the team members in each of them. And they had to go away for about half an hour, and they had to gather everything that they would use to teach a patient about periodontal disease. So they had to gather, things they had in their practice, and then they had to put together a presentation between the 4 of them, or however many were in the group. And they had to put that together, and they had to teach as if they were going to teach that patient about periodontal disease. And then what they did is they actually taught the other group and me, and they presented it to us, and they really enjoyed it. And it was really interesting to see the differences between the 2 groups as well. But that was quite a nice thing to do. Maybe that's something that you could think about doing as well, and having some, not necessarily role play, but that kind of, interaction, going away, looking at some things, putting some things together, and doing like a little presentation, because that's a good way of learning as well. So that's team meetings and looking at those different things and then this all helps then to when we start putting all these protocols in place. So partly what we want to do, and I've put this in here because it kind of does work, and particularly I know we've asked about the NHS, and we'll talk about that later, which is a slightly different thing. But if you're in private practice, private practices are businesses, and as are NHS practices as well, but a private practice definitely has business. We have to make sure they're productive and they're profitable, because otherwise we can't open the doors and we can't be providing a service and care to the patients. So it does make people feel a bit uncomfortable when you start talking about being productive and profitable, because and I'm the first person to struggle sometimes with dealing with fees, and that's because I'm in this profession to help patients with their oral health and to improve their oral health and their well-being more than I am to, on the financial side of things. But we still have to make sure that, that we are being productive for our practices and that we are being profitable. So we need to make sure that we look at that and consider that as well, in all aspects, because, we all have to earn some money somewhere. So making sure that the goal for every practice should be to establish a really good, successful dental hygiene department, and making sure that is a good profitable part of your practice. Often the dental hygiene side of things is kind of the main hub of a practice, and that's where a lot of the focus can be. And for those hygienists and therapists out there that are keen and enthusiastic, this is your thing. That's what you can do. You can work hard to build that part of your practice. When people are, in my role for BSDHT, I've talked to a lot of different members, particularly over the past 18 months, and people are struggling sometimes, they're trying to get patients in, or it's difficult to get patients, or they can't, their books are quite quiet. And I see it on the network about people, and they say they've got, I don't think it's so much at the moment, but we go through those phases where it's quiet, the books are quiet, patients are changing their appointments. And it's how you can then look at that and say, well, how can I make sure that I am full? How can I make sure that, I'm getting the patients in, that I'm seeing the patients? And there's ways that we can do that. And again, that's for probably another day, but there are ways we can do that. We need to make sure we educate and support our patients to attain and maintain optimal oral health. And that's our primary concern with our patients. And definitely as being a dental hygienist, that is always my primary concern for my patients, is I want to educate them and I want to make sure that we support them in maintaining that optimal oral health. And then obviously we need to make sure that we generate a healthy profit margin for the practice as well. So there is that aspect to it as well. And as I say, a lot of people feel uncomfortable with that, but it is a fact of life, and it's just something that we have to deal with. Okay, so when we've got our patient, so we start off with our new, or we can have our existing patient, and this is kind of like the flow chart we've just looked at before. So we have our new patients, we've got a healthy patient, we've got a gingivitis patient, and we've got a perio patient. And then the perio patients are going to become supportive therapy, they could be non-responsive, and that's actually more localized to the pockets and to the treatment rather than the patient. And then you've got your non-engaged. And then you'll see in this little circle at the bottom here, I put oral hygiene visits for children. And I've just got 2 slides on that because I really think that is important as well. This obviously focuses very much on adults. But I do just want to just have just a minute just to indulge myself with a children's appointment because I think it's important, really, really important. So as we talked about before, we're making sure we have that clinical examination, making sure we go through our health history, dental history, and social history, and then establish the patient's goals. So it's always good if you've got that new patient, or if you've got a patient that you've been seeing for quite a while. Sometimes their priorities change, things change in their lives and their priorities change. And so it's always good to reestablish what the patient goals are, what they want to achieve. You can be working really hard with that patient to make sure, or you can think that you see the patient for the first time, you introduce yourself, you dive in there, you do your pocket charts, you do your BPs and everything, and you start on all your explanations of periodontal disease, and you want to tell them everything that you know, and they might just be there because they just want to have a little bit of stain removed from their tooth for a particular reason. It doesn't matter, it might not be probably because they're unaware, but it may be that, they, at that moment in time, that's what they need, that's what they want. And so it's good to maybe establish that whole, what that patient's goals are, what do they want to achieve, what is their long-term goal, what is their, short-term goal. Okay, so looking at that, making sure we've got to do our full extra oral examination, and then intraoral of all the hard and soft tissues. We're going to do BPE, and then, or if we need to do pocket chart, we'll do that, and then any necessary radiographs. Okay, and then and any photographs, including intraoral. And we will just talk a little bit about photographs as well in a little while. So healthy patient. Clinical gingival health, as we said before, that's now that's on the classification. It actually is there, and those would be BPE codes 0, 1, and 2, and there's no obvious signs of any incidental recession, bone loss, and they have bleeding scores of less than 10%, and they would follow treatment step recommendation 1. And then if you've got a gingivitis patient, and that could be localized gingivitis, or it can be generalized. If it's localized, it'll be somewhere from around 10% to 30% bleeding on probing. And then generalized would be anything over 30%. And then BPE is obviously 0, 1, and 2. And again, no obvious signs of any incidental recession, bone loss. And again, those patients would then be recommended to follow step 1. And then our perio patients, code 3, no obvious signs of any incidental recession, and then on the radiographic assessments as well. And then we would obviously do a 6-point pocket chart, and you would do your pocket probing depths in those particular sextants that are code 3s. So you don't need to do a full mouth one, you would just do the ones that are code 3s. And then you would start on the initial therapy, which is follow step 1, basically. And then we would review after that, okay? We'd review 3 months later. So then we would, so when we do our review, so we do our follow-up review. So if we have no pocketing, so basically if we've had an engaged patient, we have, those pockets that were maybe 4 millimeters, they're now down to 3 and 2 because the inflammation's gone down. We have no radiographic evidence of bone loss. And they're still, and then they can continue on the pathway for 0, 1, and 2. So they would just go back and continue with step 1 and just be maintained indefinitely. And you would just keep an eye on those patients. And then if they did have some pockets that were over 4 millimeters, 4 or more, and there was any radiographic evidence then of bone loss, then we would then continue with we would carry on on the code 4 pathway, which we'll talk about in a second. And then we would make sure if it's non-engaged patient, we would repeat step 1. Otherwise, if they're engaged, then we move to step 2 or referral. And then periodontal patients, code 4, obvious signs of incidental recession and bone loss, radiographic assessments, full periodontal assessment, including 6-point pocket chart. So you would do your full perio assessment on that. So plaque, bleeding, pockets, recession, mobility, everything, vacations, the lot, everything. You just do everything. Incidental, and then your initial diagnosis, is it molar incisor pattern? Is it localized periodontitis, so less than 30% of the teeth? Is it generalized, over 30%? And then you would stage and grade that patient appropriately. And again, you would start with step 1. So you're always going to start with step 1. We're always going to start there. So step 1 is all about building the foundations for and that opportunity, that optimal treatment outcome. So we're building the foundations for what we're going to do. So a really good way to start is to explain the disease and how it progresses. And we obviously have to go through the benefits and risks. Now, I don't know if you can see it on here. Oh, you probably can't actually, because I think my screen's on there, so you won't be able to see it. But this is these slides, these images are taken from an Oral-B flip chart. It used to be quite a big one. Now it's just a small little one. But this is one of the, it's a very basic and very probably old-fashioned way of doing it. But it's actually probably the best way to show a patient about the progression of periodontal disease. And I use mine all the time. I have it out all the time. It's got marks all over it. It's got pen lines all over it and everything. But that's what I use for my patients most of the time. And then so obviously with that, we would then explain to the patient the progression, what causes the inflammation, what causes the bone loss, and what the ultimate, outcome could be if we don't deal with this and we don't treat it. Okay. Then we would obviously talk about risk factors. So obviously we've got those systemic health risk factors, everything that we talked about with regards to systemic health. We have, and then we've got things, alcohol, smoking, poor diet, all those things as well. So we're going to talk about those. We're going to establish those with those patients and address those situations, address those with the patients and establish this. So what we would do then is we're going to explain this to our patient. And this is quite a long time ago. This photograph was taken actually now, and my room's somewhat different. In fact, now I have a big screen. But one thing I would always recommend is to always have two screens. If you can, in a room, have 2 screens, one for your notes and one for your patients for educating, so the patients can see. They can see everything. So you'll see on this. So where I used to have my bracket table, which was here in front of me, when I had a perio patient, I used to get the pocket chart and the bleeding scores and everything on the screen, and then I would have my flip chart on my bracket table, move my instruments and have my flip chart, and I would be going back and forth between the flip chart and the patient's either their radiographs, their plaque and bleeding scores. And so everything was very visual and they could see everything that was going on, and you would explain everything to them. And when it was like this, it was very, you can tell it was pre-pandemic, because we sat right next to each other. There's no PPE, and that was about the extent of PPE then anyway. But it was it was a really good way to sort of talk to your patients and really just get to on top of explaining everything with regards to educating the patients as well. So that was always a really good way to do it, and I still do it in that way. But my screen is now on the other wall. And so it's maybe not quite as easy, apart from the fact that it's a big wide screen now that I have, which is very nice, very nice. Behaviour change is part 2 of the step 1. So looking at ways we can talk about behaviour change. There's loads of things out there now about behaviour change, and one of the things that's come from this pandemic, I think, and a lot of the webinars last year was about behaviour change and how we can motivate patients. You'll see on this too. So I found this is a hygienist called Elizabeth, called Liz, and she had this little campaign, and she's going to do it again next year. And I did it with some of my patients in practice. Unfortunately, we only got wind of it quite like mid-end of January. So it was a little bit late, but we're going to be on it this year, and we're going to really promote this for her, because it was a great sort of initiative to do an intervention. And basically it's 28 days And it says it's called flosserary because it was done in February, but actually it's basically incidental cleaning for 28 days. And the kind of the evidence shows on behavior change that if we can get patients to change or to, you know, to do something the same for 28 days, then it takes a bit longer. They say it takes nearly 40 days to create a change, but you kind of, after 28 days, it's much easier to implement. This paper as well, which I put here, was another one which was 28 days, and this was to stop consuming added sugar for 28 days. I actually took part in this this piece, and I did the 28 days of no added sugar, and I carried on, and I pretty much have carried on, and and it's no added sugar, so you can still have fruit and certain things, but you just don't have things with sugar added to them. So so sauces with sugar, and basically what you have to do is you just end up making everything yourself, instead of buying it from the shops. So but I took part in this for Tim, and it was a really good thing to do. I did it towards the end of the first lockdown, and it really did make me much more aware of diet and sugar. And it's not a diet, it's just more being aware. And then there's a lot of these kind of things around as well now that are like awareness weeks and awareness months, and this one I found was 100 miles in May for mind. So that's kind of like a positive thing. So where Tim is saying let's stop something and let's cut something out or reduce something, Liz has said let's do something, and Mind is saying let's do something. So it's kind of like those changes. So rather than saying don't do something, let's do something, let's be positive about it. So, you know, if we do this, we're going to help improve this, this and this. So so these are just some kind of like interventions, things that you can sort of look at, ideas for behavior change as well. Obviously, it's good to make some goals, to set goals with your patients. You know, we try and set goals, and we want to make, you know, help our patients as well. So have some goals with the patients. What would they like to achieve? You know, can they, between now and the next visit, can they bring down their plaque and their bleeding score to, you know, if it's at 50%, can they bring it down to 30%? Can they bring it down to 25%? You know, and how they're going to do that. So like a specific goal would be to reduce the bleeding score from 50% to 25%. So we can measure that because we're going to redo their bleeding score next time. Is that achievable? Well, yeah, if they brush their teeth, if they clean incidentally, it's more than achievable. Is it relevant? Yes, it is, because we want to help to reduce that inflammation, and we have got a time on it, because we're going to say by the next appointment, which is in 2 weeks, which is on Wednesday, the 8th of September, we're going to see if you can do that. So there's your SMART goal for your patient, and you can easily do that with a patient. So so look at those kind of things and work with those patients on those goals. Dental photography is a really good way to educate and motivate your patient, and I'm just going to whiz through this because I don't want to get too far behind. So there's lots of reasons why we take photographs, but one of the most prominent ways, and one of the good things about photographs, is it's a good way to educate and motivate your patient. You can use intraoral cameras to do that. You can use other cameras, you can use your phone, you can do all sorts you can use the big cameras, but just having photographs really does help as well. You can see, this is one that I took. We've got a new camera at work, and I'm still getting to grips with it, and particularly when I'm trying to get a bit more intraorally, but when it does take photographs, it takes the most amazing photographs. And you'll see that this is on the lower right, and I wanted to get this in because I was trying to figure out where you get this one in, but this is a patient who I saw a couple of months ago now, actually, and she came in and she thought, and when she was explaining how she explained that she had this swelling on the roundabout on the lower right, it sounded, she said, because I just pop it and it goes away and then it comes back again, and it sounded to me like a mucocele. And I thought, oh, it's probably just kind of like a mucocele or something. And she opened her mouth and I looked and I just went, ah! And that swelling was enormous. And yeah, it was huge. I ran and got someone else to come and have a look. And so, yeah, so basically she's had a few appointments with the endodontist on that one. But it was interesting, her description of it. It was like nothing. It was just like, oh, I keep getting this like little lump on the side of my tooth, and I pop it and it goes. And I thought it was something, you know, but it was pretty massive. It was pretty huge. Anyway, so photographs are good for all sorts of things, for acknowledge, for recognizing things, for history, for seeing improvements, for seeing deterioration, for seeing buccal swellings that you think it might be a mucocele or a little kind of, just a little draining sinus or something. Photographs are very useful for all sorts of different things. We're going to talk about procedure analysis in just a short while, so I won't go into too much into that, but I'll explain that a little bit more in a short while on that. This is just demonstrating how you can fit in photographs as well, because a lot of people say, yeah, but how am I going to fit that into my appointment times? And then we need to reduce the risk factors. So we need to talk to our patients about reducing risk factors. And so, how are we going to do that? What interventions can we have in place? So we've got, smoking interventions, we've got alcohol. We need to make sure that we're removing any plaque retentive factors that are, contributing to the inflammation and to this disease progression as well. So we're going to do that. These are really good, and I'll just show you this as well while I'm just looking. These are really good infographics that BSP have on their website, and they're really good they have diabetes, they have pregnancy, cardiovascular, I think, as well. But there's a few different ones of these really good infographics that are quite good to send to patients and to maybe back up some of the information that you've given to patients as well. Before we start doing any actual educating of our patients and motivating the patients, we need to consider how we're going to communicate with the patients. So are we going to do it through, how does that patient best communicate with us? Do we do it through the written word? Do we do it by listening? Do we do it by talking, or do we do it by writing? So how are we going to communicate with our patients? And then also consider the patient's learning styles as well. And it's always a good idea to make sure you've got different things that patients can do, because everyone learns in different ways. Some people learn more auditory, so by listening to things, listening to maybe podcasts and webinars and, listening to us. Most people learn visually, and that's not always just about photographs and vision, but more about kind of reading, those kind of things. And then people obviously can learn kinetic, so touch and feel, and that's really, really important. And I think the kinetic part of it is very, very important from an oral hygiene point of view, because they need to understand how it works or something works. So it always refers to oral hygiene instruction, and I've put in brackets coaching, because that's really what we should be doing. We should be coaching our patients. We should be working with our patients, like if you belong to a team, if you belong to a sports club, how are we going to educate our patient? How are we going to coach? We're coached. We're not taught or instructed. We're generally coached. We're given the tools, we're given the information, and then we go away and we practice and we do. Okay. So a couple of things, I'll do the coaching part of it first, then I'll come back to the choosing the correct products. Actually, I should have done it the different way around. But coaching is basically telling, showing, and doing. Okay, so tell a patient, show a patient, and get the patient to have a go. And also copycat technique as well. And copycat technique works really well, because what you do is you get the patient to copy what you're doing. So you always get the patient to copy what you're going to be doing. I've put this little, some of you might recognize this. This is the Brush DJ app. And this is a really good thing I used to use it a lot for the kids, and you can use it for adults as well. But basically, it's basically an app on your phone, and it links into your music on your phone, and then you set it and you brush your teeth basically to the music. And I was getting my patients to brush to music for years and years and years. And someone came up with the Brush DJ app, and apparently it's the only dental app that's kind of approved by the NHS or something, or Public Health England or someone. So it's got approval by someone. I think it's the NHS or Public Health England or both. So that's a really good way to do it. The other one, and then choosing the correct products. Now, this is something that I learned a couple of years ago when I was doing some ITOP courses, which is all about toothbrushing and oral hygiene instruction. And when we're looking at choosing products for our patients and what they should be using, there's three things that we should consider. And one of them is being acceptable, so the patient can use it well and it's acceptable to the patient. So there's no point in telling a patient that they need to go out and buy the most expensive Sonicare Oral-B electric toothbrush, if they really can't afford it, they need to have something maybe that's not quite as expensive. Or, if they're an older patient, poor dexterity, you're not going to get them to use maybe a manual brush if they can use an electric brush better. Making sure that these things work for the patients. Make sure whatever you're going to give them is effective and can be effective and they can use effectively. And also make sure that it's non-traumatic as well. And I think those are 3 things just to bear in mind when we're doing it. So not everyone's going to be the same. Not everything's going to work for the same. I remember years ago someone saying, do all your patients use an electric toothbrush? And I said, well, no, not really, because it doesn't work for everybody. I mean, we all know electric toothbrushes on the whole are better than a manual brush, but or you can get better results with them easier with an electric brush. But it's not appropriate for everyone. Not everyone likes using an electric brush for one reason or another. So, not everybody's the same. Everyone's going to be different. So first of all, when we get our patient in, we're going to disclose the patient. Disclosing is a really good way just to demonstrate where the plaque is. They can see it. It's more visible. And sometimes it can be quite alarming to that patient as well, and can really make them go, oh, wow, I didn't realize I'd missed. So, do that. Then you're going to make sure you've got your right toothbrush and what's appropriate for that patient. Are they going to use an electric toothbrush, a manual brush, whichever? Okay. The evidence shows that, the evidence does show that, both can work equally as well. But there is probably more of a swing towards a power toothbrush these days, just because of technology and the effectiveness. And I think mostly with an electric one, because of the timers, it keeps that patient engaged for that amount of time. I know I have the new IO one from Oral-B, and I've been using it since I got it last June. And if I haven't got a full 2 minutes to brush my teeth, I don't use it because I don't like the sad face on the little screen. So I make sure that when I'm going to use it when I can do my 2, 3, 4 minutes or whatever, how long it's going to take. So there's lots of, so it can work either way for patients. So whichever works well, go with that patient. But I generally do try and sway those patients, if they're using manual, if they can try and see how they get on with the electric one, we will have a go with that. So this is a good before and after with the brushing. So we've disclosed the patient, and then what we do is we go around with the brush. And so I will show them with the toothbrush first, and then they will have a go as well, and they start brushing. One thing that we do when we're doing this is we don't use any toothpaste on the toothbrush. And I always recommend to patients not to use toothpaste when they're brushing, particularly on the buccal surfaces and on the lingual and palatal surfaces, because as I explained to the patient, that's for the gums. When we're brushing and we're helping the gums on that part. And if they use the toothpaste, first of all, particularly the electric brush, it gets very messy, but also the sodium lauryl sulfate in the toothpaste can actually dull down the senses, so they can't feel where the bristles are as well on the tooth and on the gingiva. So I always make sure that they brush without toothpaste. Also, I do it without toothpaste in the surgery because I want them to see that it's actually the toothbrush that's working, and do it disturbing that biofilm, removing that biofilm, and not the toothpaste, because a lot of people think it's the toothpaste and it's not. And then I'll explain to them that the toothpaste, they put a smear of toothpaste on their brush, do the occlusal surfaces last, and then just spit it out and don't rinse it off. And that's how I would usually recommend to the patient on their brushing. But we always do brushing without any toothpaste on in the surgery because it's less messy, but also they can see that it's actually the brushing technique that's removing the plaque or the biofilm rather than the toothpaste. So this is a before and after, and it's a really good way to do it and actually get the patients to do it. With Oral-B, they have the test drive heads. So you've got a disposable head, you can use it on the patient, get them to do it, get them to feel how it is in their mouth, and get them to practice. That's that kinetic way of learning, and it's also can then be replicated at home as well. And then also the same with incidental cleaning. So again, before I do pick up any instruments, I would always go through with the incidental first and then carry on with their brush, do the brushing, incidental cleaning before we do any other instrumentation. And then they can see that's what's working. Again, You know, we've got single brushes, we've got TP brushes, and there's various other millions of different incidental brushes. There's floss, probably not so readily used as much as it probably was once, but some patients still need to use floss. I always have some floss around just in case. And then these little incidental sticks are quite handy as well. Some people don't really like them and don't advocate them that much, but because they, you know, for whatever reasons. But sometimes from a patient point of view, it's actually, they're quite easy. And if you've got a patient that's maybe either never done incidental cleaning before or has been using floss, they're quite a good, if you can get the right size and it's appropriate, then you can get them going with those first to get that feeling of cleaning incidentally quite easily, and then move them on to TPs. And sometimes I have patients using like the little incidental sticks, maybe instead of like the red, orange and pink TPs. And then once they get into the blue and yellow TPs, then they can use those. So I would say blue, I always do blue upwards is fine TP wise. And the smaller ones, if they want to use something like that, they can. But by doing it regularly, they're going to see an improvement. And that generally does motivate them as well. And they're generally quite easy to use. So I know some people, it's a bit sort of, you know, some people quite, some people don't. I find them quite good with patients from a patient point of view. I think the patients quite like them. They do it more and it really does help, and it does seem to help them. And then once they get into the habit with that, we can show them and explain to them that actually these aren't big enough now. You need to start using the TPs, and then they can see the difference. And it's quite surprising how many patients will then go to using a bigger TP once they've established that that's not working so well. As we said before, you know, we've got to do, then the next step is the professional mechanical plaque removal. Again, so PMPR, and this would be supragingivally mainly. And then, so obviously with powered instruments, with hand instruments, and I've also put in the air and go as well. If you've got quite a healthy patient, gingivitis patient, that can be quite handy as well. And obviously a lot better, you know, in a non-COVID environment, a lot better than prophy. Okay, so we're definitely going more on air polishing rather than prophy now, because it's much less traumatic to the enamel surface. And then obviously then setting the goals, setting their recall as well. So making sure we set appropriate intervals with regards to their gingival health, and then when we're going to see those patients again. Okay, so that's what we would do on that. So that's your step one. That's step one. Step 2 and step 3 are quite similar, apart from there's just a couple of odd little bits and pieces. So you'll see the change again. We're going to go back over. Repetition is always key to learning. So we're going to go through oral hygiene, risk factors, behaviour change. We're going to keep doing that again at step 2. And then we're going to do subgingival instrumentation. That can be done again by power, hand, or a combination of both. The evidence is showing that, you know, equally you can have do quadrant by quadrant, or you can do full mouth. Full mouth, depending on the patient and their systemic health, obviously if there's a lot of inflammation can cause a bacteremia, so you have to be a bit careful on that. Quadrant by quadrant, which is what I was taught years and years ago when we were training, is sort of seems to be back in a little bit more now, but that's more from that behaviour change point of view. So you can keep reviewing the oral hygiene rather than seeing them for maybe 1 or 2 sessions for full mouth debridement and disinfection and that kind of those terms. We can be doing quadrant by quadrant and seeing the patient more regularly. So we're going to get more interaction, more, and we can keep reinforcing the oral hygiene, the behaviour change, the risk factors. So it's more contact, it's those like every contact matters. It's making sure that we're seeing those patients regularly. So you can go with a bit of both, you know, the evidence is there for both, definitely for both. There is, this is a maybe considered. So in the review for the S3 level guidance, any sort of adjunctive systemic antimicrobials was it may be considered, and this would be done through a periodontist really, so it would be their recommendation. So so I've put that one in just, but they said it is may be considered, it still is. And also the same with with sort of chlorhexidine mouth rinses and things like that. So after 3 months we're going to reevaluate, and then as we did before we'll do unstable and stable. Sorry, I'm just making sure we don't get too far behind. And then step 3 is managing the patient's non-responding sites. So again, you can see it's the same again, repetition. We're going to go back into those moderate pockets that haven't sort of still there. There's that residual inflammation. So we'll go back into those and check those. Those ones that are 6 millimeters and over, we may want to check, is there another reason? So is it a perioendo lesion? Could it be a root fracture? This one was quite an interesting one. I put this one on with this upper 3. This was a patient I saw a few months ago, and she'd seen the dentist because she was a new patient and she had a fracture on a wisdom tooth that was fractured. And then I saw her for hygiene, and I probed, and I was doing my probe, and my probe went palatally straight up, and as my probe went up, the suppuration, just all the pus and everything just came out. It was bleeding, everything. And I thought there's something, and I could feel that there was just nothing there. It was really, and I thought there's something not right here. I thought it may be root resorption, but actually, as you can see, I told the dentist, and he took a PA when he saw her. Well, I informed the patient first and said I was very concerned about it, and I brought that to her attention. And then obviously mentioned it to the dentist, and he took a PA of that area. And then I said, oh, how did you get on? What was it? And he showed me. So basically, she just had it was massive decay on this, and it was subgingivally on the upper 3. So, but it created a really, I think it was like about 7 or 8 millimeter pocket, but it created that pocket there. So, you never know, but could be, there's lots of different reasons why we might have those 6 millimeter pockets that just don't reduce. So referring for pocket management. So any like pocket reduction surgery, any kind of bone loss that we can kind of regenerating surgery as well. And then supportive therapy is step 4. Again, you can see in that supportive phase, we're always going to keep reviewing the oral hygiene. We're going to keep going over the brushing, reviewing those behavior change and those risk factors as well. It's always constant, always constant. And then we're going to target any specific areas that we need to. So any of those residual pockets that we need to just work on, maybe with some local, just make sure we keep getting in there. We'll just do this for just 1 second. This is real. I do think this is quite important, and we probably don't do enough on the children's side of things. But in the practice where I work with Linda Greenwell, children have always been a big part of our practice. And there's huge benefits for it. And I see it because I've been there now 25 years next week. I see it because a lot of these patients are growing up. And this young chap here in this chair, he is now 21. And he came to see me just a short while ago. And he came in and he said, I have to just tell you, Diane, he said, I made this appointment by myself. My mum didn't even ask me to make this appointment. I just did it on my own bat. And I felt like I'd achieved something. I actually really did think. I've seen him and his brother and his 2 sisters since they were quite little. And I was quite proud actually that he looked in his mouth. He said, I think I need Diane's help here. And so he came to see me, and we did initial appointment because he hadn't been in for a while. He's been at university, and then with COVID and everything. So we did initial appointment and then a follow-up appointment, and we're right on top of it again now. Brushing great, using his electric toothbrush, incidental cleaning. He's using the little incidental sticks, thinks they're fab. And so because of that, he's doing it every day. Huge, massive improvements. But by seeing him as a child and working with him throughout his, in those formative years, has really instilled it in him now. And so that when he looks into the mirror and thinks, this isn't good enough, I need to go and see Diane, that for me is a big plus, is a win, okay? So it's really important that we start with them young and we keep working on the brushing, teaching them the brushing, and keep reinforcing that oral hygiene and that importance, because it will pay off as they get older, most definitely. Procedure analysis. This is just, so we've gone through all these things. We've got all these things we need to do in an appointment. And there are lots of things that we do need to do in appointments. And so one of the ways that we can do this is what we call a procedure analysis. Now, this is one that I did for us for a particular appointment for an adult localized or generalized gingivitis patient. So what you do is you make a list of everything that you would like to do or you need to do within your appointment. And what you do is you time it, and you time it over 3 separate appointments, and you time it and you make a note. And then what you do is you take an average, and that's how long you should have for that appointment. And that's how long you should aim to have for that appointment. And that's the same for, and then there's one here for subgingival, super and subgingival PMPR as well. So the idea is if you can work to get that structure of an appointment, like, so you have your list of what you want to do, you formulate that plan, make it into a good structure, and then you time everything, time each section of it. So how long does it take to see and greet the patient? How long does it take to review the medical history, social history, and the risk factors, to ask the patients any concerns since the last appointment? So you go through each of those. How long does all this take? How long do all these things take? Some patients it will be quicker than others. And particularly when you're at seating and greeting the patient, because then they have to tell you the whole, life story. So what we would do then is we go through this, we make that list, we time everything. And what that does, I've gone the wrong way. What it then does is it makes sure that it kind of forms that flow and a structure that's consistent within that appointment. So you always know where you're starting from, where you're going to finish, and you know what follows in that appointment. You also know what the appropriate time is when you're scheduling appointments, and it reduces running late, which I think is what I'm doing because Mish has just appeared now. It's all right, you can stay. I'm nearly there. I can whiz through the rest. It reduces running late. So this is what happens. It helps to reduce any stress from the clinician's point of view and also from a patient's point of view, because you're not running late, or you shouldn't be. From new members of the clinical team, it has really good reference points. So if you've got someone locum in your practice, they can go and check it out and see what they need to be doing. So you keep that consistency there. Good for new team members as well to understand what we're doing, and they might have some input about changing things around. But also what it does is it helps to form the correct fees as well, and to ensure the correct fees are in place, which then leads me on to this, which I'm going to whiz through right now. I'm nearly there, I promise you. Okay. And then basically with regards to fees, it's basically reflecting, the fee should always reflect the quality of the education and the treatment that you're being provided. So a lot of people always base, and everyone's guilty of it, of basing fees on time, and it shouldn't really be on the time. It should be on the treatment and what we're doing, the quality that we're doing, the quality of the education and the treatment as well. It should make sure you cover your overheads and cost of equipment and materials. And at this current time, it needs to cover PPE or extra PPE and also any fallow time that's in place. And then obviously your team wages as well. And then there needs to be a profit somewhere as well. So those are the things that you have to consider. I would always say you don't ever want to be don't ever be the cheapest, because if you're the cheapest, then people wonder why. And there's no harm in being that little bit more expensive. Because if you can justify it with the education and the treatment that you're providing, then you're always going to be on a win-win with your patients as well. And they also value it as well. You'd be surprised how many patients see a hygienist for ages and ages, and you work with them, and it's happened to me more than once, and I work with them consistently and consciously with that patient for ages. You refer them to the periodontist and they pay 3 times as much, and all of a sudden it improves. Isn't that right, Mish?
Yeah.
It does all the time. And then they come back to you and they go, yeah, I know, it's amazing, isn't it? And it's because they just had to pay 3 times as much. So be like, make sure that you it's all justifiable. Now, for Brogan, this is the flow chart. Sorry, I'm going to whiz through it a bit because we're getting a bit short on time. But this is the flow chart that I grabbed out of the, this is the document from BSP. I think it's on their website now. I think I have a pre-released version, I think, because it's not a formal document. But this shows you how this would go with regards to NHS and UDA banding. So step one, like first course of treatment, basically, I think everything from what I can see, it all looks to be band 2 payments. For most of it, it all seems to be band 2. There is a reassessment here at band 1, but mostly, if you want to do it, if you want to do a screenshot, Brogan, then make sure that you do that. Take a screenshot of it if you want. I'm sure no one will mind. But yeah, and that would be so. But it seems that most of it is kind of band 2. And the other thing as well to look at, if you haven't already, which you probably have, but is that healthy gums do matter as well, because that's very much tailored towards NHS payments and banding as well. But this is, have a look for that one, this particular document on the BSP website, because they have, it's definitely, I think it's there now. I think I've got a version. You get all sorts, when you're in these organizations, you get all sorts of things before they're out. So yeah, just have a look at that, take a screenshot, and then you've got some kind of reference there on that one. Okay, and then just lastly, just to finish off, I always like to finish off with this because I just think it's really important. And being a team member, I like to make sure that we're all thought of equally. But delegating out to the team, making sure that you all, that you utilize all the team. You know, this is our practice. Jada, bless her, is on the end there. But you know, we have quite a big team now in our practice. When we started, it was Linda, me, Nicola, and Sarah, who was one of our nurses. And then we had specialists, and that was about it. 2 nurses, we had another nurse. You know, we were a very little team, and now we're much bigger. But we're all utilised, and we all, you know, we all use our full scope of practice in what we're doing. So a good team is a group of people that are working and playing together. That's the thing. This was Teamwork in 2020. This was our Zoom team meetings. And we did them every Tuesday morning throughout the first lockdown. And we met at 10:30 on a Tuesday morning. And we had Richard, who's our periodontist. We had Jude, who's our endodontist. We had Ian, who's our orthodontist, and Benny, who's our associate, as well as Alison, who's our retired therapist, and our admin team, our nurses, and myself, Sophie, and Rosanna. We're the current hygiene therapy team. So, but we were all on there, and we used to meet every Tuesday morning, and we planned going back to work. We had a start. The first meeting was, is everyone okay? How we all doing? And then after that, it was planning to go back to work, and that's what we did. And that's how and that was our teamwork last year. And this was teamwork before the COVID pandemic set in. Actually, that was taken in February of last year, that photograph, and it was Richard because he wanted him for his. You know Richard, don't you, Mish? Yeah. He wanted him for his Instagram page or something. So but yeah, so and we do, and we work very well together. I work, you know, I have to say that Richard's probably, apart from Roz, Roz, who used to work with us years ago, he's probably the only other periodontist I've worked with in our practice that we actually really communicate, and we actually verbally communicate quite a lot, which is good. So and we work very much as a team. And so I know exactly the right point to make sure I refer to him, and he knows when he's got to refer back to me or Rosanna or Sophie. And we do work very closely with him as a group, as a you know, team as well. So and sometimes, you know, I'll have a patient in, and then something will happen, or there'll be something, and Linda will say, go get Richard to come have a look, or come get Jude to have a look. So we all work very, very closely together. So by doing that, we have a happy working environment, which we do. You can see we're all very smiley people, but we do. There's a lot of respect amongst the team, and also with the patients. Patients have a huge amount of respect for you when they can see you all work together, because no one's above anyone else. We're all there together. And then it makes for a much more profitable and productive practice. And basically, a successful practice with a happy team and happy patients is always going to be a win-win. And there's the websites, if you want to have a look at them. There's always loads more reading, always a lot of reading. I've learned that hugely, tons of reading to do. Those are the references from this evening's lecture. And I'll say thank you to Action and Optident, because they supported on this one, didn't they? And I'd just say thank you. And if anyone has any questions, and I hope that was okay.
Dan, you might want to turn the light on in your room.
Have I gone really dark?
Well, it was light when we started the presentation.
Sorry. There you go.
Excellent. So thank you so much for a comprehensive presentation and some really practical points in there as well. Let me just see if there's any other questions, because I think you've covered most things. If people want to get off now and finish the talk, I would just want to thank Diane, and I just want to go through a few things. There will be a CPD feedback link, so you can fill that out in the usual manner. That should come through with an email to you if you've attended today. The other thing is next month we have Riazia talking about occlusion. That's the first step of a two-part series. So we're honoured to have him talk next month. I'd like to also just thank the rest of the sponsors, including Kerr, including Densply, Denplan, and the other sponsors. There's like a whole load of them, Optident and Action. So yeah, if you can also, if you'd like to interact with any of those and get any special offers, there'll be little links in the feedback form. Let's just see if there's any other final
There's a couple on the chat
before we wrap up. Yeah, no, Dan, I really like your point about the fact that that there's the fees are set by not just the time that you spend, but by your education and the quality of that as well. I think that's really kind of takeaway as well. And I think one of the things that happens quite a lot is that, particularly with oral hygiene instruction, and I think we're all becoming more aware that, and I think this is something that we as a profession, we need to work on as well a lot more, is that, you know, that you always get, you always hear the stories of the patients who complain because all the patient did was, all the hygienist did was talk to me about brushing my teeth, you know, and I was going to get my teeth cleaned. And actually, no, we're not. We're there to educate them. So, and sometimes, you know, patients get quite upset because they feel that because you haven't gone in there with some instruments and what you've been doing is talking about brushing, they just feel a bit kind of like, oh, but actually that's the most important. And I think it's that communicating with the patient that actually this is the most important thing that we can do for you. So, yeah. I think, also when you do like structure of the appointments, we didn't really do that so much, but you know what's the most important do earlier on in the appointment, and what's towards the end is less so, basically. So I've actually flipped my whole appointment around now, pretty much. Well, the sort of trick, apart from the first bit, the second part of it, sort of because I usually do my instrumentation, then oral hygiene to finish. Then you run out of time and you just cut it short. Now it's oral hygiene, then instrumentation, or something, airflow, whatever. Yeah. So. Any kind of final points? A couple of points. In terms of, did you have any reservations, or does the practice have any issues around fees associated with child hygiene appointments? I don't suppose that you have, because you've been doing it for a long time, but one of the things is that certainly against an NHS background where you know, children under the age of 18, I believe, is you know, they don't have to contribute at all towards those sessions. What does that look like in you know, in your practice, and what are the kind of fees you're setting for child hygiene? So we have a child has 45 minutes, and I think the fee is something like about 80 something pound. But that's our practice, you know, that's our practice. It depends where you are. But as I say, we've, you know, children have always featured quite heavily in the appointment. We also are quite fortunate that we do have a proportion of our patients are from the American school. And so the American school, and because they're from America, in America, it's slightly different system. So a lot of them are already into having hygiene already. So it's kind of a natural course. But for a lot of our patients, like our English patients that have grown up there, it's just, I think we've just always instilled it. And I think, you know, for those people who have heard of Linda and know about Linda, a lot of people think that she is a specialist. I mean, she's a specialist and we have a specialist practice, but we also have a family orientated part of it as well.
And so it's just a natural course of events that you know, the kids are seeing. And we've just always encouraged it. It's just always been part of what we do. And we always, you know, promote the importance of it, you know, the importance of toothbrushing, diet, you know, preventative stuff, so fluoride, fish seals. So we have a fee for the actual appointment. There's a fee for fish seals, you know, those kind of things. And we just make sure that we keep seeing those patients regularly. And actually the parents want it. The parents actually do like it. They do like it a lot. And they value that as well with their kids. Yeah. And maybe, you know, maybe it's that, I mean, we're in Hampstead, so it's maybe that area that we're in as well that helps. But even when the practice I've worked not too far, just around the corner from where I live up in Manchester. We, you know, that's quite you know, it's a nice area. And there's potential there. The dentist doesn't push it that much, but when I worked for him, I did all the time, and I would try and get the children in and push that sort of thing, and it did work, and the patients did like it, the children did like it. Yeah, there is a value
Up for it, right? So you need to make sure that everybody sees that value. And
yeah, it's just seeing that value, and you know, and you've got to, it's like everything, you know, if you start that patient off like early, then you're getting them into good habits for when they get older. And as we saw from, you know, like the risk factors, you know, when they're getting into their 30s and 40s, that's when, particularly with perio, that's when that, you know, prevalence starts to increase. So if we can start working with them, so the little one that was in his cricket whites at the age of 10 is now 21. You know, it's now quite a big input. Like he literally said to me, I went and got him from the waiting room, and he's like double the size of me. He's like so tall. And I just looked, and he said, I'm here. He said, my mum didn't make me make this appointment, you know, I rang up and made it myself. I was so proud of him. I think we both were quite proud of each other. You know, but I did, and I felt, you know, he said he looked into the mirror. He looked in the mirror like a few days before, and he looked at his teeth. He said he just thought, this isn't good enough. I think I need to go and see Diane. And that's what he need, you know, and he just thought to himself, I need to go. And that, for me, that's it's actually quite a nice achievement. I think I've told a few other people about that one, and they went, yeah, but he's 21. He should know to make an appointment with you. No, they don't. No. So, but yeah, it was, for me, it was quite, and actually I had someone else who did that as well. I had a moment of realization. I've had two of them recently that have had moments of realization and thought, I really need to get myself into gear here. So, you know, it's good. We've created that. We've already got them on that track and that path. So yeah, it's good. It's good.
Excellent, Dan. Thank you so much. We could talk about perio all evening.
Okay.
We have a 9 o'clock kind of finish, and
yeah, that's fine.
Other things I'm sure people are going to be up to. So again, it leaves me to thank you again for a lovely presentation, very comprehensive presentation. And yeah, we'd love to have you back, maybe talking about something different like whitening, or something different in the new year as well, which would be really great. And yeah, please, all the delegates that are still on, do take advantage of any of the offers that are there from the sponsors as well. And it just falls on me to say thank you very much for attending, and we will catch up next time at our seminar program. Thank you so much. Thanks a lot.
Thank you, Mish.
No problem. Bye.